So we're trying it again. We went out completely on our Zoom went out on us yesterday, so we were unable to get up and rolling. Clyde did some great work. He went back and found out yet another system. I think this one's called StreamYard, and we are up and transmitting with that. We went ahead and started a little bit early today in case this didn't work. Clyde, just let me check and make sure you can hear me. Can you hear me? Great, excellent. So today we're going to cover a lot of issues rather than just sit and wait. For the people that do come in and watch and join us later, we'll go ahead and let them know what we're looking at today. It's mostly on medications. We're going to cover a lot of different types of medications for the virus. Start with the clinical trial on Kaletra or Kaletra. It's lopinavir, ritonavir. Don't need to remember any of those names. And I'll tell you why. It didn't work, but we'll talk about that in just a few minutes. These are some HIV drugs. We're also looking at other drugs, some drugs that appeared to work some with Ebola. They're called protease inhibitors, different types of drugs. Not getting a whole lot of good stuff out of any of them. But you know what? That's sort of like what we've done as a culture, and that's what man tends to do. Ignore prevention and then go into a panic when they get the disease and then hope that there's going to be a treatment for it. We've talked about that so many times. We know very well how to prevent this disease, and it's with not catching it, not putting yourself in a place or a mode or an environment where you can catch the disease. There are people that have to be out there to take care of others, like healthcare workers. Those folks are being trained a lot on how to avoid this disease. So every one of us has responsibility for ourselves and our own health. And everybody needs to remember that, again, it's like that old quote, you ask for who the bell tolls, it tolls for you. If we protect ourselves, then we're protecting others by decreasing transmission. I've got some of my own personal story to share with that. I'll share that story. Again, I'll get into, there's an issue which is creating some misunderstanding and some, quote, fake news, end quote. And I'll go into that. It's just a quick warning to those of us who may not be totally up to speed with some of the last minute changes in YouTube. And it's where, you know, I think YouTube did some stuff to try to help, and very well-meaning, and for the most part, it is well-meaning. But again, every new solution creates a whole new set of problems. We'll talk about that. We'll talk about some other drugs that are being looked at hard for treatment: Remdesivir and chloroquine, hydroxychloroquine, Avigan, which is favipiravir. Again, all these names don't need to remember. Just remember what. The ones that make sense. And out of all of these right now, none of them make as much sense as preventing transmission. Out of all of these, the ones I'm using most are hydroxychloroquine and zinc. Haven't gotten access to zinc quercetin. Oh, I mentioned in one of my recent videos that all of a sudden, I had run out of my own zinc, which I usually supplement with, and and all of a sudden it appeared. I couldn't get any more on Amazon and some other places. This is it. This is Nature's Bounty zinc, and I got a call from one of my friends and one of the volunteers that works on the channel. His name is Tyler Bourne, and he said, "Did that come in a wacky looking package, zebra print?" And I said, "Yeah." And he said, "That was from me." So thank you again, Tyler. And again, the only things that I'm using right now are zinc for myself. I'm not using plaquenil or hydroxychloroquine for me because I'm staying indoors. I'm staying isolated from others. I've got some physicians, for example, that are, and some other, physicians, grocers, other people that are critical public service workers right now, and I've offered hydroxychloroquine, or which I misspelled. You know, you're going to find a lot of errors on this on these slides. Anyhow, those are the things I'm using, and let's go into the details if you're ready. And right now, I can't tell if you are because of the way the software that we're using. So under the fake news category, and be careful what you read and what you see. Here's an example of what's going on. And you see this a lot with CGTV, Chinese government TV, which is, you know, for any of you that choose to put a lot of trust in what information the Chinese government's putting out, and even putting it out in English, so you know who that's targeted for. I've seen several of those, and it made me do a double take and a triple take. This one is not from Chinese government TV, it's from something else. But here's the thing, don't misunderstand the juxtaposition of the story with the statement below, coronavirus information, CDC. What the YouTube has done is this. They've, in order to help decrease misinformation coming out, under almost any of the YouTubes now that have to do with coronavirus, you'll see coronavirus disease information from the CDC or coronavirus disease information from the WHO. And this is what happened to me last week. One of these, I was looking up stuff on CGTV, and they continued to have talked about reinfection. And again, this is one of the more dangerous places for assuming some misinformation. Reinfection would be a huge problem. We've already got enough problems dealing with this pandemic. But if it turns out that people, Clyde, the thing just got ended by the host. Oh, okay. I started to, I'm glad I didn't say what I was feeling. So, so where were we? Oh, reinfection would be a huge, huge deal. We covered it a couple of times in other videos. That would mean, you know, like some viruses, and very few viruses, but some viruses do this. It doesn't matter whether you've been infected before or not, you can re-get it. I do not, as a person experienced in dealing with pandemics and epidemics, I don't think that that's going to be a functional issue in this case. It certainly may be an issue where a few people have it, but it's not like that's going to be it does not appear at this point to be something that's going to be a major factor in developing control of this. Now, if you misread the juxtaposition of these two titles, CDC and woman tests positive for coronavirus for second time, weeks after initial recovery, you start to think the CDC put that out or blessed it. No, they didn't. Again, that's where the YouTube is trying to say, here, if you want more CDC-related information, here's where to click and here's where to find it. It is not the CDC saying that. And in fact, if you look at the CDC top facts, top 5 facts, fact number 3 is, from them at least, you're not infectious after you've gone through quarantine, after you've had your infection and been through it. So, you know, we can all bang on the CDC and criticize them for test availability and a bunch of other things. But I think they're right about this issue. I don't think that that's going to be a big issue. And so don't misread these stories. Enough on that. Let's move on. I want to share some personal notes. And again, you see a bare slide here. I was making that 15 minutes before this event. Sorry, we've got a lot of stuff going on. I was ended up taking a call from our governor's office to help plan this national testing program. I was making some calls with my family, and here's just to share some personal notes around what we're dealing with here. On Sunday, for example, Saturday, we agreed we're going to start doing daily updates. They've been very well received. Bottom line is, again, I've dealt with a lot of epidemics. I've been on a couple of governors' task force for the AIDS epidemic, and then later again for flu pandemic. I trained in this at Hopkins. I trained folks that had worked at the CDC to manage these. It's a space I know, and I'm very passionate about this. I do have some things to contribute, so I'm very passionate. Well, after agreeing to start doing this every day and getting Clyde geared up to where he focused on this priority with me, Zoom went down yesterday, and we don't understand why. We think it's because everybody and their dog, now that they're locked up at home, is starting to use Zoom, starting to get the picture. I was able to get my Sunday school class, for example, to use Zoom. There's another Sunday school class that we used to attend in Franklin, Tennessee. They're now on Zoom. So again, somebody else called me who knows that I use this, and they were having some problems with it. Clyde went on to the Zoom help desk, and there were 195 people ahead of him. So Clyde went out, did some other work, again, came up with this new software, StreamYard. It's got a green-headed duck on it, and it's like, okay, we're going to try that now, and we're going to keep trying. We're going to keep trying to get that information out there and get access for people in terms of information and ability for someone with at least my experience to answer questions. Regarding the testing program, well, just one other thing. And if StreamYard goes down, we're going to try Google Meets. And if the Google software programs go down as well, then we're just going to start. We're going to release a daily on an upload. So we're going to continue to try to get as much information and share as much information as we can. Back to the testing components. Yes, that's continuing to go. Now we've got a small army working on it. We've got about half a dozen nursing and medical personnel. One of our folks who works in the lobbyist area was able to find a professional studio. It turns out the professional media group is located right here in Lexington. They offered to do a lot of this pro bono until we get the financing programs up and working for it. And they said, Doc, we've got a studio that we've shut down right there in Lexington. It turns out it's about 5 miles from my house. I shared with Janice that, yeah, you know what, I'll agree to do it, because they said, look, it's been shut down. We'll put one person in there with you and start, one videographer, and start producing content for the retailer employees, for people that are thinking about getting the tests, et cetera, et cetera, et cetera. You know, given what I do and the passion for this, of course, I was ready to jump in and agreed to it. My wife, Janice, obviously didn't like that because she's been frustrated about me not liking her going out to get groceries. But here's what happened. I got up this morning and looked at those numbers, and I thought, dang, I'm not so sure that the U.S. is not going to become another Italy. And I'll go over those numbers in just a minute. The numbers are dramatic right now. We're adding 35,000 cases a day for the past 2 days. The U.S., so here's the thing, Europe is clearly the epicenter, obviously not China. The rest of the world has far surpassed China. Europe and Italy is the epicenter for existing cases, but if you start looking at the U.S. and new clusters, I personally think the U.S. is rapidly becoming, if not already, the epicenter for new transmission. So I think the next 2 weeks are going to be critical for the U.S. in terms of potential containment for transmission for this disease. Let me repeat that. I think the next 2 weeks in the U.S. is going to be critical for potential containment of this disease and flattening that curve. Again, we're not talking about people avoiding this forever. We're talking about, or even avoiding it until we can get a vaccine which we can use. And I'll just make the parenthetical statement. I don't think we're going to wait for a year for a vaccine, because we're going to start looking at the risks of going out against this disease versus the risk of some long-term effects. Even Guillain-Barré with early vaccine deployment, I think we're likely to end up selecting maybe an earlier vaccine deployment. But again, that's out of my pay grade. That's just a thought. The bottom line is, I don't think anybody would disagree with me that the next 2 weeks are critical for the U.S. in terms of slowing down transmission and flattening that curve. If you want us to do that, we all need to participate. That may be the most important, I think it is, that's the most important message that we have right now. Take social distancing, quarantine, isolation, keeping transmission down. Take that seriously and take responsibility. You're going to be saving your own life. You're going to be saving other people's lives. Every time you save your life by decreased transmission, you're going to save 10 more lives down the road. This is in geometric progression right now. So after seeing those numbers, by the way, I called my friends back up and I said, guys, yeah, I was going to take some risks to get this a more professionally edited message out there. The studio's near me. It seemed worth the risk, but now as I look at what's going on with the numbers, I think we need to make do for the next 2 weeks. So my plan is to stay here, make, sort of jerry-rigged content. We're doing what we can. And our little team is doing a heck of a lot better than we would without them. I really appreciate what they're doing. And at least it's not me holding shaky paper up in front of a webcam. Again, we've got, just to share some personal family issues, one of our family members is a grocery worker, and that family member has lung disease and is a smoker. And I've worked with that family member a few times in the past, trying to respect that person's identity and that person's desires and concerns about their own addiction. They just started less than a year ago, and they admit now they are way addicted and don't think they could quit. And I've said, look, here's the thing. I have respected you. I haven't pushed very hard. However, up until this, it was more of a long-term risk. By the way, it's not the nicotine that kills you with smoking, it's the tar. And here's the issue right now, very specifically with COVID-19. COVID-19 is killing young people too. It's not that young people are totally safe. And especially young people that have had lung disease, and especially young people that are smokers, and especially young people that have lung disease and are smokers. So if you could just consider maintaining your nicotine addiction and switch it over to a patch and Nicorette or whatever combination of nicotine you can get other than pulling smoke into your lungs. We made some progress on that discussion. So obviously very concerned on a personal basis. These are my close family members. Meanwhile, someone from the governor's office called, and there's a lot of stuff going on there. They've been concerned about putting testing in parking lots where there may be food outlets, grocery stores. And my question was, here's the concern. My question was, here's the concern. There's we want people to be able to access it and know where it is, and be able to find it, find community areas. So, the response I got was very good. It was very enlightened. You know what? We never thought about that. We've obviously got a lot of stuff going on in our office, and we'll start considering that. So again, rapidly moving situations, environments. We're all trying to do the best we can. And just to let you know, the governor's office that I'm talking about is Bashir here in Kentucky. And one of the things I have to say is I am so proud. He caught a lot of junk for coming out so early and making strong statements. But the bottom line is he saved countless number of lives. by slowing this transmission down sooner rather than later. And thank you, guys in the governor's office, for making that happen. And hopefully we can consider some of the changes and practical concerns that we have starting up a national testing program. If someone will remind me a little bit later, I'll give you some more updates on the testing program. There are moving targets there. For example, this is an aerosol transmitted disease, so we have to, theoretically at least, for people that are doing testing, you would need a negative pressure room, a positive pressure air source, a lot of things that just frankly are not available. They're not going to be available for us. They're not going to be available for anybody else that's doing these testing programs. But you know, we're going to have to do the absolute best we can with the supplies that we got. It does look like we'll have appropriate gowns, appropriate gloves, appropriate N95 surgical masks. And did you know that an N95, there are N95 industrial masks, N95 surgical masks. They're different. The surgical masks have a little bit more body fluid liquid protection, which is going to be a big deal in this environment. We also think that we can get the face shields, all of which will make a big, big difference. But this will also then go into significant programs with talking to employees. People have to volunteer to do the testing, not just force somebody to do testing. Again, we'll provide other information if you have questions on it. I covered this a week or two ago. I went into my own isolation 2 weeks ago. People thought I was a nut. Now, not so much. Stock up, stay at home. And this is not just people that are 60 years old and above. This is not just diabetics. This is not people at risk. Here's another thing. When it gets scary like this and people are finally getting attention, they tend to go from laughing at it to panic. Neither one is appropriate. Don't laugh at it. This is serious. I think we all know that. I don't think there are many people we have to convince of that anymore. But now we need to convince people not to panic, because there's no reason to panic. We're going to go through some unprecedented pandemic activities, and we have the countermeasures. We know what we need to do. So we'll have to adjust things in terms of the reality of supplies, demand, what we have, but we know what we need to do. And again, just a reminder, it's not just lung disease, it's not just diabetes. Diabetes, I mean, the obesity epidemic drives diabetes, but again, obesity is a big deal for this as well. Be thinking about that. Now, let's get to the medications. Kaletra. It's this appeared in the New England Journal on March 18th, 2020. A trial of ritonavir, which is Kaletra, in adults hospitalized with severe COVID-19. That I believe is has been a protease inhibitor used in HIV. Why is this important? I kept this slide very clean for a purpose. It's important, and the background is this: no therapeutics have yet been proven effective for the treatment of severe illness caused by SARS-CoV-2. And I'll repeat it. No therapeutics have yet been proven effective for the treatment of severe illness caused by SARS-CoV-2. Now, I would, even though that was in the New England Journal, even though I repeated it twice, I would add a couple of clarifications. ICU beds are critical. If we can do the right things in terms of providing ventilator support for someone, we have to do some things that we've talked about multiple times before. Number one, ventilator support. Number two, the docs will know this too. If they have you on a ventilator, your family members, they'll decrease the tidal volume a little bit to decrease the inflammation. Number three, they'll have to paralyze you to keep you from fighting that ventilator with those smaller tidal volumes. And number 4, they'll have to put you in a prone position with your face down. Those things will take your mortality rate from something like 40% once you get to that level of disease where you have acute respiratory syndrome, down to less than 10%. So major improvements. And yes, proper ICU care is a very effective help. Now, which takes us back to an epidemiological perspective, to a comment that we've all made many, many times. Let's flatten that curve. And how do we flatten that curve? Not by going to Fort Lauderdale Beach and Miami Beach for spring break. I don't say that to make anyone feel guilty. I say that to get us to, again, realize that we have effective countermeasures. We may have ignored them in the past. We may have made mistakes. Look, we all make mistakes. Let's just focus and start doing the right stuff at this point. So back to the lopinavir, ritonavir trial. Lopinavir, like I said before, is an HIV protease inhibitor. Ritonavir, and that's for you medical people and science geeks. Ritonavir improves the half-life. It's a cytochrome P450 inhibitor. Again, most of you are not going to know or care what any of that means. The bottom line is this is an AIDS drug. And here's what they did. Randomized controlled open label trial with adults hospitalized with confirmed SARS-CoV-2 infection, causes the respiratory illness, the COVID-19, and an oxygen saturation of 94% or less. What does that mean? That means they've got some bad problems in terms of ventilating, getting oxygen into their blood. 94% or 95% and above, that's what all of us have, most of us have. That indicates that you are what we call ventilating and perfusing well. In other words, you're getting oxygen out of the air and into your bloodstream. If it's 94% or below, you're not doing so good in that area. And when it's because of SARS-CoV, it's because you have inflammation that is just surrounding the alveoli, the air sacs that you breathe, that provide the interaction between air, oxygen in the air, and your bloodstream. And if you get too much liquid filling that up, the oxygen cannot get from the air into the bloodstream. And if you fill it up too much, you can't get any air into the air sac anyway. So that's what this ventilation is all about. That's why they were looking at these folks. Now, they randomly assigned patients to a 1-to-1 ratio of either the Kaletra twice a day for 14 days, in addition to standard care or standard care alone. The primary endpoint was clinical improvement, defined as time from randomization to either an improvement of 2 points or discharge from the hospital. Won't go into what the 2 points were. It doesn't matter because no benefit was observed. So again, I told you in the intro, and here's the gory detail. Yeah, we've got a bunch of antivirals out there. We're trying a lot of them. Don't treat this like we have tended to treat heart attack, stroke, flu, tons of other illnesses. Just hope we're not going to get it, and then hope for a cure. And in so many other areas of life, we acknowledge that hope is not a plan. It's the same thing with medicine. Hope is not a plan. And hoping for a cure is not the way to treat these things. Prevent it. Don't put yourself in a position where you have to hope for a treatment that's going to bail you out. So back to the overall content for this video. We talked about some personal issues that I shared. Thank you for your patience. Again, I wanted to just share some of the challenges that we're working through on our side right now. Wanted to give some updates. Speaking of which, Clyde, I'm going to come back out of the show mode here and go into some of the updates on the that I talked about with the coronavirus map. And then we'll go back into the show mode for that. Let me make sure. Okay, so Clyde, just confirm if you would by phone that we're seeing the CDC map. So I mentioned to you, thank you, Clyde. So I mentioned to you earlier on when we were talking about looking at the numbers today and what's going on over the past 2 days. So here's where we were just a couple of weeks ago. So we were all looking at China. China was the big place. It was the big focus. And you may remember, those of you who've been watching the CDC, this entire area was dominated by China. This was China now, and China has, to a large extent, stabilized. As we know, you've heard it, I'm not the first one to tell you this, for a few days now, the epicenter of cases has been Europe, not China. But again, here's one of the things that I mentioned before. Europe may be the epicenter of cases because you've got these big red dots here, but look at the number of tiny red dots in the US. Now, what's the difference between a big red dot and a tiny red dot? The more cases in a specific location, the bigger the dot. So when we started looking at this, again, about 2 weeks ago, we had one tiny dot in Washington State. Within a couple of days, that had turned into that first death. Now look what we've got in the US. And think about it. Think about, you know, again, everybody being walled elbow to elbow on the beach in South Florida. And I'm not so worried about being outdoors. I'm far more worried about the transmission that occurred there in the hotels, in the bars, in the restaurants in the evening. And again, it wasn't just South Florida, it was everywhere. The US has not been taking isolation seriously enough. And look at it again. It looks like a young child with chickenpox or measles. It started in one area, but it's all over now. There's no place in the US that's immune from this. And there are places like New York, Washington, and California where those dots are getting really big. So if you think, you know, each one of these dots represents a case, and maybe each case represents a dozen, 2 dozen, 3 dozen infected people that don't know it, you can think about why the next 2 weeks is so critical for the US specifically. Up until this weekend, I had personally been very optimistic that maybe the US was going to not become another Italy. I still think that's a possibility, but I don't know. Look at the number of cases that have happened here over the past couple of days. So in order to do that, go back and look at this. I mean, these are worldwide cases. Again, 30,000, 35,000 a day. Come back and look at this list. If you look at the US, we're now number 3 in terms of confirmed cases. Gosh, what were we, 12, 15, just what, about a week ago? So again, I'm very concerned that the US is going to have a very bad next 3 weeks. April Fool's Day is not going to be a fun date this year. Now, one question. So you look at that one dot there in Russia, you know, a small number of dots in Africa and South America. A couple of things. Number one, it reminds me of when I was on the governor's AIDS task force in Maryland. What was this, 40 years ago? It was when we were just beginning to see the AIDS outbreak starting. And what you saw was what you tend to see with most of these pandemics. They start with the people that are wealthy enough or have one reason or another to travel from one country to another. Usually, again, wealthy or professionals. And then what happens is they start spreading the disease. And that's exactly what's happened here. It's people that are traveling from one country to another. tend to start off with some relatively well-off people, and then all of a sudden, kaboom. And that's what's happens usually. That's what's happened with this one. Again, this is no longer people that have traveled outside the U.S., obviously. Now, there's another website which is really helpful in terms of looking at this, and it's the Bing coronavirus. So it's Bing is, I think, is Microsoft's web browser, and again, you see a lot of similar stuff. They have their own map. You see again, epicenter is clearly Europe. Here's Italy. Italy is the #2 country now in terms of cases. No, is it #2 or #1? Let's go back and take a look. Yeah, it's still #2, 59,000 cases, rapidly overtaking China with 81,000. And the U.S. is running a very rapid third. I don't think Italy is going to be able to keep pace with the U.S. over the next 3 weeks. So go to Bing, bing.com/COVID, and you can start getting a lot more information. They tend to have some good things in terms of graphs and some great news links in there that you don't find on the Johns Hopkins map. So again, I hope this has been helpful in terms of that update. Clyde, I'm going to go back to the deck and go back into presentation mode. So we talked about the clinical trial for Kaletra, the AIDS drug, which turned out to be a bust. That clinical trial, by the way, was done in China by a host of Chinese physician researchers. They've been doing a great job in terms of documenting a lot of what they saw earlier on. Let's look at a couple of others. Now, if you go to the CDC website, and hopefully that made it to the deck. Yes, okay. So the CDC has a component on their website where they mention a couple of coronavirus meds. Pardon me, by the way. Sometimes you'll hear me just slip into HIV talk. I lived and breathed HIV pandemic for 6 years, 30, 40 years ago. So sometimes I catch myself, sometimes I don't. The CDC has a lot of information, obviously, on COVID-19. And they actually mentioned they've got a site for therapeutic options for COVID-19 patients. And this is worth reading. There are no U.S. Food and Drug Administration, FDA-approved drugs specifically for the treatment of patients with COVID-19. At present, clinical management includes infection prevention and control measures with supportive care, including supplementary oxygen and mechanical ventilatory support when indicated. In other words, a ventilator, an ICU, and if you look at our case rates right now, that's what I'm worried about more than anything else, is whether we're going to actually be able to flatten the curve or whether we're going to go outside of our ICU capacity. An array of drugs approved for other indications, as well as several investigational drugs, are being studied in several hundred clinical trials that are underway across the globe. So there's a ton of research going on with this, with a lot of medications. Nature magazine, by the way, has a great article where they begin to systematize all of the different clinical trials that are going on. Basically, you go into some deep science and genetics, as you often do with Nature magazine. I put some of that in this deck this weekend, Saturday, but when our systems crashed, I lost a lot of the information that was on the deck. Right now, I don't know if that's going to still turn up or not, but we'll see. That article basically looks at the genome, the proteome, and what all these things mean. Those are the genes in the cell, the proteins that are in the cell and the human body and metabolism, and links them almost in like a well, for you mathematicians and scientists, multiple regression type of thing. Starts looking at which ones are very important and starts focusing on those proteins, those genes that, and those medications that impact those. Like, for example, with the previous one, the Kaletra, where we're looking at protease inhibitors. As you know, ACE2 receptors, that's a big deal. There's a lot of focus on drugs around the potential for that. And again, as many of you know, that's where zinc and zinc quercetin and chloroquine and hydroxychloroquine, that's their space. And I think I do have some information in the remaining deck that does speak to that. So I'll plan to talk about that a little bit. Back to the CDC comments. They said, you know, there's an array of drugs approved for other viruses. They're being studied across the globe. The purpose of this document is to provide information on 2 of the approved drugs, chloroquine and hydroxychloroquine, and 1 of the investigational agents, Remdesivir, currently in use in the United States. So Remdesivir. Remdesivir is an investigational IV drug with broad antiviral activity. It inhibits viral replication through premature termination of RNA transcription. Again, what that does is, this is what we call an RNA virus. For those of you who remember, and don't worry if you don't, and don't worry if you don't care, I'll be beyond this tech geek talk in just a second. The genetic material. Viruses are kind of interesting and weird in terms of living creatures, and many of us would say, well, they're not really living creatures. All they are is a protein coat, and then they've got genetic material inside, and it's sort of like they're like a tiny, quote, living, end quote, hypodermic, which go in, they inject their genetic material, and they hijack our genetic material mechanisms. So RNA is the genetic material that they use. There's RNA and DNA. We use both. And so when you see something that terminates RNA transcription, in other words, it's stopping that virus's ability to transcribe or rewrite, write the RNA virus genetic material. So that's Remdesivir. It has in vitro, meaning not inside the human, not inside the cell, but outside the cell. It has some activity against SARS-CoV-2, and in vitro and in vivo, in other words, in living creatures, activity against related beta coronaviruses. In other words, the coronaviruses, if you go back and you read Michael Osterholm's book, don't even have to read that whole book. It's a long one. Just go to chapter 13, and he'll talk with, he nailed it, and he talked with you about it. Coronaviruses have caused multiple significant outbreaks, SARS, MERS, and we knew that this was a problem. We had ample warning. We just, as usual, we're human beings. We didn't take it seriously. So we don't have enough masks. We don't have enough test kits. We don't have enough, most of all, public understanding of the seriousness of the situation and the need to isolate. So we're learning a day late and a dollar short, like my grandma used to say. So again, Remdesivir stops RNA transcription for both in vitro and in vivo in other related viruses. So there are currently 4 options for obtaining Remdesivir for treatment for hospitalized patients with COVID-19 and pneumonia in the United States. For those of you who are listening to this, you're probably not hospitalized. So again, this is IV, by needle in the vein, and it's for hospitalized patients. NIH has a couple of double-blinded studies. There's some folks where it's just like, I forgot what you call it, but the patient is in dire straits, and it's like a mercy chance. You have a couple of programs like that. Now, hydroxychloroquine and chloroquine, that's the other drug that has been listed on the CDC therapeutics site. Hydroxychloroquine and chloroquine are both oral prescription drugs that have been used for treatment of malaria and inflammatory diseases like lupus. Chloroquine has been used for malaria treatment, and hydroxychloroquine used for treatment of rheumatoid arthritis, lupus, porphyria, cutaneous arthritis, some other things, again, inflammatory diseases. Both drugs have in vitro activity against SARS-CoV-2, and other coronaviruses. So, with hydroxychloroquine having relatively higher potency against SARS-CoV-2. And we've covered this in other videos starting, I think, early last week. A study in China reported that chloroquine treatment of COVID-19 patients had clinical and virological benefit versus a comparison group. Chloroquine was added to a recommended antiviral for treatment in COVID-19 in China. Based upon limited in vitro and anecdotal data, chloroquine or hydroxychloroquine are currently recommended for treatment of hospitalized COVID-19 patients in several countries. Both chloroquine and hydroxychloroquine have known safety profiles, meaning they can be dangerous. Hydroxychloroquine especially, it can cause death by a heart dysrhythmia. That's to start off with. If you stay on it for 5 years or so, like some of these lupus patients, it can damage the back of your eyeballs, even to the extent of causing blindness. So these drugs are not simple like metformin. They're not like zinc. They're not like, you know, some of these harmless things. These are some significant drugs. I've written a few scripts for hydroxychloroquine for, I've got some patients that are doctors still having to see patients, and patients that we fear have COVID-19. So due to higher in vitro activity against SARS-CoV-2 and its wider availability in the United States compared with chloroquine, hydroxychloroquine has been administered to hospitalized COVID-19 on an uncontrolled basis in multiple countries, including the United States. So that's some brief part of the story on hydroxychloroquine and chloroquine. I will tell you, when I mentioned it before, some people didn't know. Specific to this channel and specific to connecting dots with risk factors, before I confuse the issue, hydroxychloroquine has actually been approved for diabetes treatment in India because it also decreases the blood sugar. So interesting connections here. How does it do that? We covered that again in other areas, other statements. Favipiravir. What is that? How is that? That's a medication that was developed by a company called Toyama Chemical of the Fujifilm Group. It has some activity against many RNA viruses. It's been getting a whole lot of press. The Guardian, Japanese flu drug, clearly effective in treating coronavirus, says China. I'm not there yet. I hope it works, but you know, this is one of those things where there's a lot of lay press on this issue. There's not a whole lot of research right now there that's indicating that Avigan or however you want to pronounce that, is actually doing a lot. But I can tell you there's a lot of people looking at that, and we'll know a lot more over the next few weeks. One of the good things about what's going on with this virus is that we can do these clinical trials. You know, for something like heart attack and stroke, it takes years to find out if a drug's actually working or if a therapy is actually working. Like a stent. I mean, it's been decades before we finally began to realize that stents don't prevent heart attack. And I know a lot of people are going to hate me for that. You already do. It is what it is. Take a look at the Courage trial and some other trials out there. But it's a very different issue for this disease. I mean, if it's going to kill you, it's going to kill you within a matter of weeks to even days. So we can find out very, very quickly if drugs like Avigan or Remdesivir or Kaletra, if those drugs are actually going to work. Melatonin? Somebody asked me that the other day, and I thought, wow, that one caught me by surprise. I looked it up after the event, and somebody asked me, and here's what the stuff I found. Here's a great way to get good sleep, and sleep will help you stave off coronavirus. Well, I mean, good sleep is critical for any kind of health. We know that. But 147 degrees west, up in Alaska, that's a brown bear, I guess, and it looks like it may be a homemade picture. So I don't know if you were actually face to face with that bear taking a picture or not. If so, I guess at that point you were probably more worried about the bear than you were about viruses or heart attacks or strokes. But anyhow, very, very up to speed lady. I've talked with her at least once over the phone. Hi, Doc. Caught the replay. Great presentation. One comment on melatonin. The theory, and emphasis I think on the terms theory, is that young children have high levels of melatonin, and that appears to be protective. It may be because melatonin inhibits NLRP3 inflammasomes, and again, that's just the kind of extremely well-informed science geeks we have watching this channel. It also preempts the cytokine storm from COVID-19 ARBs. Do I take melatonin? Yes. Personally, do I afford to take it? I've taken it off and on. I'm not a major melatonin fan. I found that other things help me sleep better, like regular exhaustive level resistance training, HIIT, high intensity interval work, managing my blood glucose, managing my my weight. If I continue to eat too much, well, anyhow, I'm going off down a bunny trail in terms of how to manage sleep. But that seems to be at least the theory according to 147 degrees west. Am I banking on it? No. But the way I figure melatonin is cheap, over the counter, and a good night's sleep can't hurt. I can't get melatonin I don't notice it helping me sleep anyway. The other stuff helps me sleep. Hygiene and exercise and other health issues, and meditation. If I wake up in the middle of the night, which I chronically do, wake up at 2 or 3 in the morning, if I meditate and slow my breathing way down, increase my, what we call hypercapnia, increase my CO2 level a little bit, that tends to calm me down and help me go back to sleep. So back to the content, and I promise we'll get to questions in just a minute. So that covers Kaletra, Remdesivir, chloroquine, hydroxychloroquine, Avigan, melatonin, and maybe the zinc, quercetin, NSAIDs slides made it in. Maybe they didn't. We will see. Okay, so the zinc slides made it. As you see, this is from MedCram. They've got a great channel. Again, it gets a little bit like mine in terms of geeky and sometimes for physician level groups, but there's a lot of people other than physicians that understand this very well. And in fact, a whole lot of the people that understand this very well are not physicians and know more than most physicians with heart attack, stroke, other types of prevention, and maybe even this part as well. Here's the thing with zinc. Zinc is great. It inhibits RNA-dependent RNA polymerase. So again, don't have to remember that. Those words are too big. Pardon me, I have to keep this on because Clyde is co-hosting and managing the tech side and communicating with me through this while I present here. So zinc, you remember we talked about a virus being a little hypodermic, which injects its own, it attaches to the cell membrane with the virus wall. And by the way, you know, we call it coronavirus. It's because there are little barbs sticking out from that virus wall. Those appear to be the key biologically to why this is killing so many people and why it is so infectious. Great Nature magazine articles on it. I had hoped to get to those, but guess what? Life has a way of getting in the way, doesn't it? But let's go back to that concept. So you've got this virus. It's a little hypodermic with its own genetic material in it, which is all RNA. It attaches to the cell wall and then injects that RNA material in to hijack our genetic material development processes. In order to do that, it needs an enzyme called RNA-dependent RNA polymerase. I'm going to make one other quick, hope to connect a dot, but hope it doesn't turn into too much of a bunny trail. Polymerase, PCR, polymerase chain reaction. That may ring a bell because that's the type of testing that we're doing for the most part. They're antibody tests which look at human antibodies that we've developed to this virus. Those are very quick and easy to do, but they don't tell you what the PCR test does. They only tell you if you've had the virus long enough to develop an antibody. The PCR test is looking to see if you have developed a lot of the virus's genetic material, if the virus has been able to hijack your genetic material production facilities. And what it uses to hijack your genetic material production facilities is that big word. It's an enzyme, RNA-dependent RNA polymerase. Now zinc, now we get back to zinc. Zinc inhibits that. As you see this right here, zinc 2+, and that 2+ means it's an ion, and that matters. We'll get back to that in a minute. Zinc 2+ inhibits coronavirus and arterial-virus RNA polymerase activity in vitro, again in the test tube. And zinc ionophores block the replication of those viruses in cell culture. So back to the 2+. Why did that matter? Because here's the thing. The cell membrane that this has to get through, the zinc has to get through in order to slow that virus RNA replication down. That cell membrane of ours is mostly lipids, meaning it's mostly waxes, oils, cholesterol. Well, because it's an ion, it doesn't pass very well through there. And here's the thing. You can get tons of zinc, like my friend and volunteer Tyler sent me, and I can really elevate my serum zinc level with it. But it's not going to go anywhere. I'll just pee it out unless we can get it across that cell membrane wall. That is what this other big word is for, ionophores. An ionophore is something that takes an ion across this cholesterol membrane. And that brings us up to the next drug. That's how chloroquine and hydroxychloroquine work. They are ionophores. And as you see in this article that was in, I think this is the article that was in the Lancet, in vitro, again, in the test tube, antiviral activity and projection of optimized dosing design for hydroxychloroquine in the treatment of acute respiratory syndrome, coronavirus 2. So what they have shown, I believe this is the article that shows that, hydroxychloroquine, both of them work. Chloroquine works, hydroxychloroquine works. That's why you saw those stated in the CDC website. That's why you see guys like me who are going ahead and writing some of these scripts in exceptional cases. That's why there's a little bit more lean towards hydroxychloroquine than chloroquine. Conclusion, hydroxychloroquine more potent than chloroquine. I've already said it, basically. It's an antimalarial drug. Zinc needs help getting into the cell. Why not chloroquine? Because hydroxychloroquine is better. Ready for prime time. Do we need to start writing this for everybody? No. Is this what it's called? Plaquenil, by the way. Is this something that you need to have around just in case? You know what? Again, let's focus right now instead of going to the going out to get drugs and more groceries and things like that, especially in the U.S. Can we just give all of this running around, getting into other people's breathing space, a break for 2 weeks, just 2 weeks. And let's look at it again 2 weeks from now. I think we'll probably not have to make that statement 2 weeks from now. Either A, we will be making some progress, and some government folks will be helping in that space, or B, the picture will be so dramatic that it will make the case for itself. Just an update. On Saturday, I covered coronavirus in kids. Bottom line is this: kids seem to get infected maybe as much as we do, adults. They also get some impact on their lungs. If you look at x-rays with kids, and this study was in the New England Journal, it was covered in, it was, again, like the other one I mentioned earlier, done in China. You get these infections in kids. However, what happens is, and you see what we call a ground glass appearance on chest x-rays with kids. And guess what? They don't get symptoms. So they're getting similar problems, but they're not filling their lungs up. They're not having problems breathing. Out of what, 13 to 1,500 kids they looked at in the Children's Hospital in Wuhan, 3 of them, I think, died or went into ICU. And those 3 kids had much bigger problems. I mean, they had huge problems already. One of them had leukemia. Another one had intussusception, where the intestine has folded in on itself. The other one had a kidney problem. All 3 of these problems were enough to put these kids in ICU without COVID. So, I just covered that. So, you know what? I wish I knew my slide deck better, don't you? I'm going to go back out now, see if we have any questions. Thank you for your interest. And at this point, I don't know if anybody's even there. Let's take a look. Well, Clyde, I can't. Oh, here we go. We do have folks there. A lot of folks. Thank you very much for your interest. Let me go back up and see if I can start responding to some of these. This is a test. Thurston Howell III calling in from Gilligan's Island. Good morning. Morton Ortiz, good morning. Our Russian friend, and I guess that's Cyrillic script, Gavril says hi from Kiev. I wish, what do you say? What do you say in Russian, in Kievian? Not yet. I don't know. Hi, how are you? James Cantor, I can hear you, Dr. Brewer. Great. Martin Ortiz. I tell you what, this dang new system, you may have seen that little green-headed goose or duck head on there. We're doing that because we're advertising you, because we're mad at Zoom. This actually has some advantages. It's simpler than Zoom, better. Good morning, everyone. I hear you, Dr. Brewer. Did you hear about the French doctor who's given an old malaria drug with 100% success rate on 40 infected persons? I am very skeptical when I say see 100% success rate, and it's not in publication anywhere. But I mean, did I hear about? I mean, we talked about that. The only things that are getting significant rave reviews from good channels, like we covered today, hydroxychloroquine. And that's the anti-malarial drug. Clyde, good morning, everyone. Martin Ortiz, unless it's fake news I just read a few minutes ago. No, well, I'm not going to repeat it about you heard what I had to say about hydroxychloroquine. Eradicator 7, is the combined treatment with hydroxychloroquine and azithromycin dangerous? Yeah, both drugs cause QT prolongation. Eradicator 7 evidently has a little bit of a clinical background there. And yes, these drugs, clearly not stuff that, you know, some people say, well, you know what, I'm scared. I didn't believe people when they told me this was coming. And oh my goodness, now it's real, and give me everything I can take. I just want to take it to keep me from getting it. Don't do that. especially with these drugs. These are not playthings. Now, I'm not avoiding your question, Eradicator 7. How much overlap and how much, sometimes with medications and other things, you get not even an additive effect, but a multiplicative effect. And both of these drugs can cause a significant heart problem, which can kill even young, relatively healthy people. It's called QT prolongation. I've had that on my list to look up for 2 or 3 days, and I told you what's going on. I'm not getting a lot of lookup time right now. I'm getting a lot of stuff done and a lot of stuff looked up, but I hope I get there. Bart Robinson, Martin, I heard about the French doctor this morning, Farouk Farr. Dr. B, so Farouk is a physician or a medical student in Iran, and he shared with us a couple of times that, guys, I'm in what's been an epicenter for a few weeks. Guys, people are dying. And by the way, it's not just it's not just old people and people with risk. Young, healthy people are dying as well. And tragically, Farouk shared with us past 2 days that he had a young, healthy cousin that died. And again, our thoughts and prayers go out to you, and as well as a lot of other people. Dr. B, trial in Iran. I think you're saying trial in Iran, 50 people given drugs, 1 hydroxychloroquine, 2 azithromycin, 3 prednisolone. Prednisolone. Why would they? That makes me nervous. And 4 naproxen. 3 and 4 of the prednisolone and the naproxen make me a little bit nervous. In 5 days, all the respiratory symptoms were gone. Could it be that easy? I'm skeptical, but we never know. I mean, one of the things, if we get time, and I covered them, I think, Friday or Saturday, there's a lot of mixed emotions about using the non-steroidal, the anti-inflammatories. These number 3 and number 4, prednisolone, it's cortisol, it's cortisone, it's prednisone, it's a major anti-inflammatory drug, which, if you consider the problem with the inflammation causing the lung issues, yeah, that's, I'm sure a lot of people are using that right now, but then you're adding it even more to it in terms of naproxen. Once you get somebody to the extent that they're on a ventilator, makes a lot more sense. I don't know. I mean, this is obviously a rapidly moving area. I wouldn't be surprised at all to find that does work very well, but again, remains to be seen. Martin Ortiz, Bart, I sure hope it's true because we need it. Yeah, we need a lot right now. We do. Joe Campbell. Hydroxychloroquine came from Germany, was stated as ineffective by Angela Merkel. I hope this is not where we start beating up on politicians again. I have since heard the tests are not panning out and are moving on to 2 other drugs. Okay. I haven't heard that yet, Joe Campbell. I could not help but notice my fellow, Al, I could not help but notice my fellow Americans totally disregarding most of the guidelines and recommendations of social distancing and staying at home. That is the biggest problem now. Al, I could not agree with you more. That's why our case map looks like a kid that's had chicken pox for about 3 or 4 days, or a week. It is now all over. And again, every one of those little red dots is not the only person infected in that space. We can very much rely that there are, again, I don't know if it's a dozen, 2 dozen, 6 dozen, I don't know. That's why we need testing so badly. Actually, because testing is so important, I'm just going to make a couple of quick comments about that. One of the biggest issues, if you go through, I recorded a couple of videos. Hopefully, we'll get them edited and get them out soon about testing. If you look at the CDC recommendations for testing, it's okay. If you're in the hospital for COVID-related disease, get the tests. Obvious, and you're not going to be making that choice at that point anyhow. Your doctors will be. Speaking of those doctors, if you're a hospital healthcare personnel, you're working on helping a patient that's in the hospital with COVID-related disease, then you should have testing. And then it starts to get into sort of a murky area. It says, well, if you've got high risk, but really if you've got high risk, manage it on a practical basis. If you're turning blue and you can't breathe, don't get a test, go get emergency care. And if you're not, stay at home. Unless you're related to a place with, quote, elevated transmission. Well, again, if you go back and you look at the map of the United States now, tell me a place. It looks like there's a place, looks like the desert outside of Nevada, and maybe some places in Wyoming don't have elevated transmission, and that's what I expect to happen. Now, why would they word that way? Why? So here's the bottom line, and they've come under a lot of criticism for it. There have just not been enough tests. Senior management at one of our partners went up to look at a testing center, and testing centers are starting to break out. I live in Lexington in a circle. There's a circle here. Inside the circle, there's a lot of doctors' offices. I usually take a mile or two walk around this area. I went walking on Friday or Saturday, and I looked over, and there's all these cars in line going up to a tent awning. Sure enough, I walked over. I was about 6 feet away from the guy in the truck in the line, and I said, "Is this testing?" He said, "Yeah." And they had the news cameras out and all that. Well, they had the University of Cincinnati do some testing in Cincinnati this weekend as well. And they, again, a lot of senior management went over there, took pictures, asked a lot of questions. They sent the pictures back, and it was like, here's an interesting, there were a few dozen people out there. I couldn't tell, looked like maybe a couple of dozen people setting up and running the testing program. And it was like less than half a dozen tests were done. Well, why was that? Because they couldn't get the test kits. So you get back to that. CDC has gotten a lot of criticism for not having test kits available. They are responsible for that. Did somebody screw that up? I don't know. I mean, I don't know. We are where we are. I will tell you this, though. We're working with a national group. They've been given the test kit components by the CDC, and they have been pretty adamant with us that they're going to be at a capacity of several thousand tests available in less than a week, maybe 2 to 3, 4 days from now. So I do expect that gets you back to the CDC recommendations for testing. And I do expect that the CDC is going to start changing their recommendations. When I have these conversations with people on our team, they get a little bit nervous because they're saying, is our medical leader getting ready to start saying stuff that's outside of CDC? No, I won't. I'm going to continue to use to create content based on groups like CDC recommendations. I will, however, if and when appropriate, when I see places where you might want to think differently, and you might want to be aware and thinking about potential changes coming down the pike. I think when we have tens of thousands of test kits available, which may be 2 days from now, my guess is the CDC will reconsider their instructions. Right now, it doesn't make sense to tell a lot of people to have a high index of suspicion, go out and potentially break social isolation to get a test that doesn't exist. If the reality is we don't have the test kits, it doesn't make sense to tell people to go out and sit in their car and breathe air outside of their home. So to get back to questions, let me see, I may have lost. Okay, so old NJB, good idea. Nana Buster. Wonder if that's, anyway, people need to stop smoking pot as well as tobacco. That is true. You know, pot, a lot of the science might indicate that one doobie, one cigarette, pot cigarette, may be about as damaging as 30 regular cigarettes. POTS actually work. POTS actually worse is it's deliberately held in the lungs. Yeah, and that's the problem. It's the tar, the junk that you're inhaling with the smoke is paralyzing your immune system to fight off this virus. Stop smoking. Well, I'm not worried about nicotine addiction. Get addicted to Nicorette and nicotine patches, but get off of the smoke right now. David Otway, we really don't know the number of infected. Yeah, well, exactly. The numbers are artificially loaded to testing only symptomatic people. David, I wish I had read your comment before I just went off on my little tangent and tirade. Thank you very much, David. Obviously, I agree 1,000%. Bob Weiss, hi, Doc, from North Georgia mountains. Hello, Bob. Good to hear from you. Thanks for the comment. Al with another comment. Mortality rates exaggerated by the number of asymptomatic people are not being counted. I agree with that. It's not the SARS and MERS with the 8 to 10% mortality rate or the 32 to 36% mortality rate that's killing a lot of people. It's these like Spanish flu, COVID-19, .2, I can't remember. Coronavirus, this one. Those are the ones with the 2 to 4%, maybe even less. It may be as low as 0.6%, especially depending on how much access you have for care. These lower mortality numbers are killing a lot more people because the bug is a lot more infectious. It gets back to that R0, that reproduction index. And as long as you're in a space where the R0 is 3 and 4, then every person is sharing it with 3 or 4 others, or on average, that's what's happening. We've got to get that down below 1. And we don't get that down below 1 by everybody going to Starbucks, or everybody continuing to go to work, or everybody continuing to go to dine in at restaurants. And I have to say this, I know one of our local popular restaurants is going crazy right now with delivery. And do you really trust the restaurant workers to not have any of this and to be handling your food? I'm sure this is going to be an unpopular comment too. It's not popular with my wife, but she's agreed to it. We're not ordering out a whole lot. Eradicator, in fact, we haven't yet. Eradicator 7's combined treatment with hydroxychloroquine. Well, we dealt with that just a minute ago. Maybe the questions are bouncing around again. Eleanor Malik, if Ford gets this, tell Clyde he's awesome. Clyde, did you hear that? Eleanor Malik thinks you're awesome. And if Clyde gets it, tell Ford he's awesome. Eleanor, thank you very much. I think you're awesome, and I really appreciate the feedback. I can tell you this. I don't know about Clyde. Actually, I do. I could not be having more fun. I don't enjoy the death and destruction that's going on, but I love being able. I'd be nuts trying to play golf or something. I really love having an impact, and I'm finding multiple places where I can have an impact. I'm suffering my 3rd retirement right now, but again, when I gave up I gave up long ago trying to just relax and not do something. I'm having a blast doing what I do. So Eleanor, I think you're awesome because you're showing us interest. Hopefully you're sharing those things, getting that information out there. My biggest regret right now is that we can't have more of an impact. We can't get this information to more people because this is not panic worthy. Panic's the worst thing we can do. Just like ignoring it all 2 weeks ago was the worst thing we could do. Now, panic is the worst we could do. Kathy Jensen Budahiri, and I hope I'm pronouncing that correctly. Is there anything we can take over the counter with zinc to help its absorption? There's the old quercetin story, and I think quercetin might be over the counter, and I apologize again. I have been working to try to get the quercetin story all cleared up so I could present it. Somebody fact check me here. Somebody help us in terms of that issue. I believe it's zinc quercetin. I don't know if quercetin's over the counter or not. Somebody tell us whether it is. Dr. Sleep Dog, how much of the increase in case numbers related to increase in testing? We just don't know. As I mentioned before, Dr. Sleep Dog, look at the difference between countries here. With the US, it's very, very spread out. Tons of like 1 and 2 case dots. Whereas you look at South America, you only get big dots there. Again, that could be because it's only in the cities, only in places where people could afford to travel. But those are also the places where the public health facilities can afford to do effective public health, which includes counting. So, yeah, right now, there's plenty of evidence that, like Africa, I mean, poor areas or maybe politically challenged areas like Russia are not getting the right information out to us. If there are 2 areas where the information is going to come out, it's the US and Europe. Now, the US does not have a whole lot of testing going on. Parts of Europe, especially like South Korea, have had significant testing going on. And again, hopefully, I hope and pray that our guys with the in the lab are correct, and that there's going to be a lot of testing capacity coming online just within a few days. Because you look at, here's another thing I looked for. I presented it a few days ago. If you look at the China epidemic line, it did the hockey stick. If you look at Italy, the epidemic line, it did the hockey stick. If you look at South Korea, where they jumped on this immediately and started doing tons of testing, case finding, basic public health. They lived through this with SARS. They took this seriously from the very beginning, not like us continuing to go out for spring break. They took this immediately, did a lot of testing, a lot of case finding, quarantining people. Here was their epidemic curve. It didn't go like that. It went like that. So we need those test kits, and we need to get more testing out there. Okay, Greg Clopton, I saw this morning that New York City is now considered the epicenter of the outbreak given the current growth. I'm not at all surprised. And guess what? This software has the same problem. If I move it just a little bit, sometimes it takes off if we got a bunch of them built up, and I skip a bunch of them. I'm so sorry if I'm skipping your comment, but I'm doing what I can. So Earthquake Targets says quercetin is over the counter. Thank you very much, Earthquake Targets. Alessio 777, what tips do you have for getting in and out of the grocery store without getting infected? Well, my wife thought she was being very smart. She went early in the morning, like 7:30, and that probably helped, with the exception that she just, number one, this is in the air, and it stays in the air for hours. Number two, it stays on the can of the food, the milk cartons. People come in, they've got it on their hands, they pick that up. And so when we got home, she put all her clothes, took all those off and put those in the wash. She put on new clothes, she washed down, and she was very careful to make sure that she threw all the bags away. But she didn't wash off like the milk carton and the egg, the cartons that all these people had been moving around while they were trying to find their food. So I'm not the world's best at telling you how to grocery shop. I've just been telling Janice, look, I've got a whole bunch of, I've got about half of these big bottles of olive oil. I've got 2 big bottles of avocado oil. And I'm planning on living off of significant oil calories for the next few weeks till this thing starts getting a little bit better control. Green eggs and ham, quercetin powders over the counter, but we just take it orally with zinc. I don't know the answer to that. Thank you very much. But again, I hope to start getting some more information. Okay, looks like we're wrapping up here. Sally Schultz, I'm sewing masks as I listen. Well, that's interesting. Our local hospital is short. I'm adding a piece of HEPA filter. HEPA filter is an insert to increase its effectiveness. Well, I hope those work. From a Kirby vacuum cleaner, pardon me for laughing. I do hope that works. I'm just laughing because that's incredibly creative. Again, let's hope it works. Mark Statham is asking for dosing on quercetin. And again, I apologize. I don't have the dosing. Hopefully I can get that looked up by the time we present again tomorrow, hopefully, if we can continue to get this to work. Farouk Farr, thank you, and God bless you for your concern for others. Thank you for yours as well, Farouk. AL, zinc gluconate does have side effects and contraindications, so please read and research before buying. Thank you, AL. You know, there's no such thing as a free lunch, and everything that we think we're doing that's just going to help us, yeah, there's always another side to that story. Hole 19, thanks to Clyde for getting the new presentation system together. Thank you, Hole 19, for the acknowledgement. Clyde did incredible work getting that done. John Woodard, should I really be concerned with going home if I don't have any symptoms and I'm being pretty careful and I want to go home? I'm out here by myself. It's excruciating. Well, John, I'm very sorry. I don't know your situation. I'm very sorry to hear that. Let me just deal with this. If you look at the map of the US 2 weeks ago, 2.5 weeks ago, when I started these, there was one little red dot. It was an active case in Washington State. And the next day, that case had died. So there was one red dot, one death. And I've showed you this a couple of times. You see what it looks like now. Let me see if I can. Well, yeah, here we go. Oop, oop, oop. That's what the US looks like now. And I have every expectation that the vast majority of those red dots are due to somebody who, A, thought they were being careful, and B, had no symptoms. So again, I don't know your total concerns, you know, in terms of what kind of isolation you've been in. Here's one thing: if you can remain isolated for 2 weeks, you've got a really, really good idea that you probably don't have the virus. You know, if you have to get on an airplane to go back home, then all of a sudden, then you've, you know, gotten back out into a place where you could have been infected. So maybe 2 more weeks. This is not easy at all. And just be aware of what's going on. But let me just repeat this again. In the US, we went from what, 1 dot in less than 2 weeks, about 2 weeks, 1 dot to 35,244 dots. What do you think? You think 5,000 were symptomatic? I doubt it. Vast majority of these people didn't have symptoms, did not know, had no clue they were infected. So that's how this transmission is occurring. I'm going to go back in, just check one more time to see if we've had any other comments. Clyde says, thank you, Eleanor Malik. Oh, thank you, just doing my job. Credits to Dr. Brewer. Well, credits to you, Clyde, too. I wouldn't be able to be doing this if you hadn't figured out how to get us back up and rolling. Martin Ortiz, doctor, I think we need to test everyone eventually. I think the vast majority of the population will get tested. I don't know if it's going to take 6 months or a year. Here's another, I'm glad you brought this up. Here's another question. One of the things that gets pushed in front of us when people find out what we're doing, oh, I've got an immediate test. You don't have to take it back. It's not like PCR, which takes hours and maybe a couple of days to grow that virus to see how much viral genetic material they have in it. It's an immediate test, Insta-test or something. I forgot what they call it. They've got it engineered like the pregnancy test. And here's the problem with that. That's looking at a human antibody. Yes, I think all of us are going to end up, or vast majority of us are going to end up getting tested over the next 6 months to a year. But which test? Number one, we're using PCR right now. Polymerase chain reaction. That's where you incubate, you get the stuff, you incubate it to see if you've got viral genetic material in there, and that takes a couple of days. It's not the ready in 2 or 3 hours with this Insta test. But here's the, so why don't we use the Insta test? Well, here's the thing, the human antibody test. You go back to the conversation we were just having about all these so many of these 35,000 cases being transmitted by somebody that was asymptomatic. Well, I don't know. We don't have the information yet, but perhaps not a one of those had any antibody yet either. So the antibody is going to happen later. It's going to be very, it's not that it's a worthless test. It's not helpful right now in terms of the upswelling, the first waves, the invisible transmission phase of this pandemic. It's not that helpful because we need to know what's being transmitted. We don't need to know yet who's immune or has antibody. Now, as we get over the hump, the antibody test is going to be critical, especially for 2 or 3 reasons. Well, am I safe to go out yet? Well, do you have the antibody yet? Well, should I get the vaccine? Well, do you have the antibody? And, you know, that's less important, and that's, what, a year down the road. But yes, I agree. We need to get a lot more people tested. We need to start doing basic nuts and bolts public health, which includes not only social distancing, but isolation and case finding. How are we going to find cases, you know, for these 35,000 cases we already have? Where did they get that from? Who else has got it? Who else is spreading that out there? How are we going to answer any of those questions and throw an isolation quarantine loop around them? Basic public health work. How are we going to do that without testing? So, pardon me, I think I'm showing some of my my personal perspectives on a problem. Bob Bell. Okay, earthquake targets its OTC. Okay. What tips do you have for getting in and out of the grocery store? I think Robert Pinsky, does metformin help with coronavirus? I haven't seen anything on that. Now, I've heard a lot of sort of underlying chatter about coronavirus, as well as many other viruses, increased and thrives in more of a hyperglycemic, you know, high glucose environment. Don't know. I mean, not a lot of, I'm not aware of a whole lot of real hard evidence on that, but I'm clearly, I ran out of glucose monitors, so I was going to say I'm clearly continuing to manage my glucose value, but don't know about metformin coronavirus. Fennell Hicks. Fennell, it's good to hear from you. Good friend of mine. Doing a lot of work in terms of personal training. Great job, Dr. Brewer. Thank you for helping us all. Thank you for Fennell. After Clyde and I went through, we had such a disaster. We were so worked up yesterday to try to get this out there for people. And Clyde tried over half a dozen times. I kept trying. We kept seeing these notes from people. Well, is he there? Is he coming in? Is it? And it just wasn't happening. So we were beat, frustrated, and dejected. And I got this little text, and it was from Fennell, who I haven't talked to and, gosh, verbally talked to. I think I've talked to Fennell once over the past year. And Fennell said, Doc, I know you're strung out. I know you tried. You did what you could. Hang in there and keep plugging. So thank you, Fennell. That was very helpful to hear that. Kathy Budahiri, you did pronounce it right. Budahiri, and thanks. So I appreciate what you're doing. I appreciate your interest as well, Kathy. Fennell, all of us, helping all of us. Thank you so much for your interest. We're going to sign out, and I'm going to see if I can go find out a little bit more about maybe dosages for quercetin and zinc. Thank you.